Hello and welcome. I, Dr. Achal welcome you to the first session of discussing Robbins review series. The first thing that we'll be starting with is neoplasia. So we're starting with neoplasia MCQs. The duration of this series will be short and we'll be discussing 15 to 20 MCQs in time. That will be followed by part 1 and part 2 and so on. So let's start with this MCQs. So the first MCQ here is, a 40 years old man has a positive stool Goniac test during the routine physical examination. So this is for the occult blood and it is positive. A colonoscopic is done and there is a circumscribed pedunculated mass and a short stalk is found in the upper rectum. So what information we are getting from this MCQ is a 40 years old man with a positive stool occult blood and it is having a circumscribed mass that is having a small stalk. So stalk is pointing towards benign, then circumscribed is pointing towards benign. So what are the options is giving? Adenoma, carcinoma, choristoma, hematoma, hyperplasia and sarcoma. So if we know all the definitions, it goes with adenoma. So what is a carcinoma? Carcinoma is malignant condition. So at malignancy will not be circumscribed and will not even have a stalk. Okay, then what is a choristoma? Choristoma is the presence of a normal tissue but it is present at an abnormal site. And hematoma is the presence, it is an abnormal mixture of cells although it is benign and it is present at the normal site. Then what is a hyperplasia? Hyperplasia is increase in number of cells and sarcoma is a malignancy of the mesenchymal tissue. So our best suited answer is adenoma. Okay, so now we come to the next MCQ. So this is a 32 years old woman has experienced dull pelvic pain. So she is experiencing a dull pelvic pain for past 2 months. Physical examination is shown right adnexal mass. Okay, so the abdominal ultrasound was done and this abdominal ultrasound shows a 7.5 centimeter cystic ovarian mass. This mass was excised and surface of the mass was smooth and it is not adherent to surrounding pelvic structures. So what is the message with this line that they have said that it is smooth? It is not a mix from somewhere else because it is not showing anything rough or patchy implants. It is smooth surface from outside. That suggests it might be a benign lesion. Then it is not infiltrating also. It's saying that it's not adherent to anything and it is not spreading out. The gross examination, this is a cyst that is filled with hairs. So hairs is not a normal thing from that tissue. On microscopy, we are seeing squamous epithelial, tall columnar epithelium. Then it is having cartilage. Okay, the cartilage is a mesenchymal and glands are epithelial. Okay, then there is also having a fibrous tissue. So it is having cells and tissue that are developing from different lineage. So this is the one that is developing from all the 3 layers, that is endoderm, ectoderm and mesoderm. So what components we can see? This is ectodermal component. It is having an endodermal component and as well as it is having a mesenchymal component. So let's see what the options are. It is adenocarcinoma. No, adenocarcinoma is a malignancy of the glandular and epithelial tissue. Fibroadenoma, as the name suggests, fibro is that is of fibrous tissue of the breast as well as glandular tissue of the breast and is a benign lesion or it has increase in glandular tissue as well as in the fibrous tissue of the breast. Then there is glioma. Glioma is this CNS malignancy. Then there is a hematoma that we have already discussed, that is the mixture that is abnormal but it is present in the normal site and it is benign. Then we have mesothelioma, that is a malignancy of the lining of the pleura. Then there is a rhabdomyosarcoma, it is a malignancy of the muscles and the specified striated muscles. Then teratoma. What is teratoma? Teratoma is when a malignancy, not a malignancy but neoplasia arises from all the 3 layers. That is ectoderm, endoderm and mesoderm. So that is what it is. It is having squamous, tall columnar epithelium, cartilage and fibrous. That is all the 3 layers. So it is a teratoma. Then we come to the third MCQ. So the third MCQ is a 62 years old man. So the first thing that it is telling is that it is a 62 years old man will have episode of hematuria in the past week. He has 48 pack years, so he has a strong history of smoking. Physical examination has no abnormal findings. Urine analysis shows 4+ protein hematuria. And then there is a cytological examination that shows atypical cells, and the cystoscopy was done that shows a 4 centimeter sessile mass. Okay, so up to now what we know, there is 64 years person who's getting blood in urine. He has strong history of smoking. So this tells us that there can be something wrong with the bladder, but then it directly tells that it is a sessile mass. So that can be a tumor that is showing hematuria but can be associated with smoking, because smoking is associated with urinary bladder malignancy also. Okay, so now let's see other part. And it is nodular and it is ulcerated. So ulcerated is one thing that mostly suggests that it can be malignant. So what can be our options? That it can be adenoma. If it was an adenoma, mostly it is not ulcerated. Then there is a carcinoma. Carcinoma can be ulcerated, can be nodular, can be sessile, can present with hematuria. Then what is fibroma? Fibroma will not present with this presentation. This papilloma is again benign. Then sarcoma. Although rare, the best is to suggest is carcinoma. Then there is the next question. The next question shows a 23 years old woman noted a nodule on the skin of her upper chest. She reported that the nodule has been present for many years and has not changed in size. So this was a nodule in her upper chest and it was excised and the microscopy was shown. So what is the most likely diagnosis? Okay, so they have given an option: fibroadenoma, hemangioma, gliomyoma, lipoma, melanoma and nevus. So melanoma and nevus will have melanocytes, and lipoma is a tumor of fat cells. Okay, gliomyoma is this will show whirling appearance and it will show muscular tissue. Then there is fibroadenoma that I told, it will show glandular tissue along with the fibrous tissue. Then we are left with hemangioma. Okay, so this picture, it is showing, this is the lesion, it is showing multiple blood vessels, 1, 2, 3, 4, multiple, these are multiple blood vessels, and it is showing red blood cells inside them. So these are red blood cells. So these are very small tiny capillaries that are arranged together, and these are showing red blood cells within them. So this is most probably a hemangioma. Now we come to the fifth question, that is a 50 years old woman undergoes screening colonoscopy as part of routine health maintenance workup. In isolation, 1 centimeter pedunculated polyp has been seen in the sigmoid colon. The excised polyp histologically shows well differentiated glands with no invasion of the stalk. Which of the following investigational research procedure can distinguish most clearly whether the polyp represents hyperplasia of the colonic mucosa or a tubular adenoma? So we have to differentiate if it is a hyperplasia or it is an adenoma. Okay, so in both the conditions we see there is increase in number of cells, that there will be increase in number of cells in adenoma as well. So how do we differentiate? See, let's see the options. So that is saying flow cytometry to quantify cells in the S phase. So it is saying in the cell cycle we'll see if there is increased proliferation, but if I think if it is both the conditions, there is increase in cell hyperplasia or adenoma, both situations it will be increased. So it is not of use. Then there is histochemical staining for mucin. So there is no point in doing mucin, so because it can be in both the situations. Then there is immunohistochemical staining for keratin. So what is the information we are trying to extract from keratin? So it will not help. Then we are saying molecular markers for clonality. So now the adenoma is a benign tumor. A benign tumor is the one that is clonal. So adenoma will have clones of cell, whereas hyperplasia will not be clonal. Okay. Now Further on, we see MCQ number 6. A 39 years old woman underwent a routine health maintenance examination for the first time in many years. A pap smear was done and the result report was abnormal. On pelvic examination, there was a red raised 1 centimeter lesion on the anterior ectocervix at 2 o'clock position, and it was excised for biopsy, and the microscopic appearance at the medium power is given in the upper. And the following is the most characteristic of this patient's condition. So first let's see the image and then we'll see the options. So this is the image. Now let's see the options. Options are, which of the following is the most characteristic? Primary neoplasm of the endometrium. So no, it is not endometrium. Elevated CA125. CA125 is a marker for ovarian malignancies. So this is also not. Then positive HSV, that is herpes simplex 2. No, HSV simplex 2 will not be related to this. Then this is primary nodule in the chest, and the E answer is no recurrence after local excision. So now let's see again. This is a full thickness involvement of the epithelium by tumor cells, but we can see the basement membrane is intact and there is no breach in basement membrane and no extension of tumor cells beyond the basement membrane. So it is adenocarcinoma, it is a squamous cell carcinoma that is in situ. So in situ squamous cell carcinoma. So it will be best if we excise it locally and it will not show any recurrence because it is completely excised and it has not reached the basement membrane. So the next MCQ is 7th MCQ. A 53 years old woman has noticed increase in malaise. On physical examination, there is no abnormal finding, but a stool GNIAC test is positive, that is occult blood test is positive. Her hemoglobin is 7.9. A colonoscopy is performed and a 3 cm sessile mass is found in the cecum. A biopsy specimen of the mass shows a moderately differentiated adenocarcinoma confined to mucosa. In CT, abdomen scan shows no lymphadenopathy or hepatic lesion. Given this information, which of the following is the best course of action? So, it is seen that she is having a 3 cm sessile mass. First, whenever we are assessing the treatment, first find out that if it is a benign or a malignant. Okay, so it is having, first it is a single sessile mass, okay, in the cecum. It is not multiple. If it was multiple, it was more likely to be a metastasis, but it is a single sessile mass in the cecum. The biopsy of the mass shows moderately differentiated adenocarcinoma, but it is very clearly written that it is confined to the mucosa, okay. If it was spreading out, maybe the modality changes, but it is confined to mucosa. In abdominal CT, there was no lymphadenopathy or hepatic lesion. So they have told very clearly that there is no lymphatic spread and not a sign of METs. Given this information, so it is very well confined mucosal lesion. What is the best mode of treatment? So it is administrating a multiple chemotherapeutic agent. So it is not very helpful to give a chemotherapeutic agent when the lesion is already inside. We have to excise it, only then chemotherapy is anyway helpful. Then observe the lesion for further increase in size. So there is no point in observing a malignant lesions. Then remove the entire colon. So the removal of entire colon can be done in a certain situation if there were multiple polyps or there are familial tendency, if there are familial syndromes that have multiple polyps, or they can be increased risk of malignancy. But this doesn't seems to be any syndromic, or this doesn't seems to have multiple polyps. So this is not the solution. Then resection of the tumor and some normal surrounding tissue. So this can be an option. Let's see the E, search for primary malignancy. When the tumor is confined to mucosa, there is not a chance that it will be originating from somewhere else. Either mucosa is the origin of the malignancy, and if it is excised along with some normal tissue around, it is most probably it will not metastasize or it will not spread. So let's go down to the 8th question. 8th question. A 57 years old woman has experienced an increased feeling of fullness in her neck, that is with 3 kg weight loss over past 3 months. On physical examination, there is a firm fixed mass in 3 into 5 cm area in the right side of the neck. A CT scan showed solid infiltrating mass in the region of right lobe of the thyroid gland. The biopsy of the mass is performed and the microscopic appearance is shown in the figure. All of the following tumors are similar morphology. Which of the following term best describes the neoplasm? So, let's see. The terms they have used is anaplastic, apoptotic, dysplastic, metaplastic and well differentiated. Okay, so let's see the image. In this image, what we can see a small cell, a large cells, then we can see elongated cells, then we can see this is tripolar mitotic figure. That is a very atypical mitotic figure. Then there are very large cells. So this is a pleomorphism in this. This is showing anaplastic characteristics. Okay, so let's see what other options are and how we have ruled them out. Anaplastic, we are favoring anaplastic. Why it is not apoptotic? Because apoptosis refers to a programmed cell death and its appearance will not be like that. Then there is a dysplasia. Dysplasia has pleomorphism. It has all the features, but it is confined. It doesn't spreads. It is confined to the epithelium. Then this is metaplastic. Metaplastic means when one type of epithelium converts to the another type of epithelium and nothing of that sort can be seen. Then how we ruled out well differentiated malignancy? It is not a well differentiated malignancy because it doesn't resemble anything. When we use the word differentiated, that means it will resemble to something that has been differentiated to like something, like it is differentiated to either like skeletal muscle or it is differentiated to anything XYZ. So now we come to 9th MCQ. This is a pap smear obtained from a 29 years old woman during a routine health maintenance examination is abnormal. She is currently asymptomatic. She has a history of multiple sexual partners. Okay, then cervical biopsy specimens are obtained and the microscopic examination is shown in the figure. Which of the following is the most likely diagnosis? Okay, so let's see the image. So in this image, we see this squamous epithelial lining is here and then this is extending. The basement membrane has been breached and it has infiltrated inwards. There is definite invasion and then there is this invasion. It has definitely invaded along with desmoplastic reaction. So we can see this has infiltrated from the squamous epithelium. Okay, so this is most probably a squamous cell carcinoma because invasion is one of the characteristic feature of a malignancy, and as it is starting from a squamous epithelial lining, this is a squamous epithelium malignancy. Then we come to the 10th, that is a 44 years old woman feels painless lump in her armpit which was not present a month ago. So this line statement gives the information that it is a very fast growing some lesion. On examination, right axillary lymphadenopathy is present. The notes are painless and firm. That gives another information that it is painless. Painless are mostly associated with malignancies, whereas tender ones are associated with infections. So, and it is firm. Firms against one sign that firm and hard can be a malignant one. Which of the following is the most likely lesion in her right breast? So, mastitis would probably be painful. Fibroadenoma. Fibroadenoma will have no nodules in the axilla. Infiltrating lobular carcinoma. So, this case possible because it is an infiltrating tumor. Infiltrating tumors can give a lymphatic tumorlets can get into the lymphatics. Then intraductal carcinoma. So, one can say that this is also carcinoma, why it's not spreading, but because it is intraductal, it is not spread beyond the ductal component of the breast. Then there is Gliomyosarcoma. Gliomyosarcoma is although it is very rare in breast, it can occur, but it is very rare. And second of all, sarcoma rarely goes and spreads through the lymphatics, mostly through the blood, although it is not hard and fast, but it is mostly through the blood. Spread is through the blood. Then we come to 11th MCQ. 11th MCQ shows a 69 years old woman has increased malaise and 10 kg weight loss. So such high weight loss suggesting something malignant. She dies of massive pulmonary thromboembolism. So there is a thromboembolism. On gross examination, the liver biopsy is shown. Which of the following is most likely? So invasive angiosarcoma, hepatocellular carcinoma, leukemic infiltration, metastatic adenocarcinoma, and multifocal hepatic adenomas. So this picture is very characteristic of metastasis, that is showing multiple lesions of variable size. Although they can be, HCC can also be multinodular, but this appearance is very characteristic of metastasis. Then there is 12th question, that is a 66 years old man with chronic cough has an episode of hemoptysis. On physical examination, there is no abnormal finding. A chest radiograph shows 6 cm mass in the right lung. A sputum cytology analysis shows neoplastic squamous cells. Metastases from the lung lesion are most likely to be found at which of the following sites? So our options are cerebral hemisphere, chest wall muscle, hilar lymph nodes, splenic red pearl, and vertebral bone marrow. So the most common site for this situation, like lung malignancy, is the nearest lymph node, because all the carcinomas first they will go to the nearest lymph node. So our answer is hilar lymph node. And if to be specifying about the cerebral hemisphere, up to half of the cerebral hemisphere metastases are from the lungs. Okay, so next is 13th MCQ. 13th, an epidemiological study for cancer deaths recorded the last half of the 20th century is conducted. The number of deaths for one particular type of cancer has been decreasing in the developed countries. So it very smartly says about the developed countries. So we have to consider that it would be probably linked to reduced incidence of infections, because that is the main difference between a developing and developed country, despite the absence of widespread screening and preventive programs. Which of the following neoplasms was most likely to be identified by the study? So cerebral glioma, that is not associated with any infection. Then gastric adenocarcinoma, it is associated with H. pylori infection. Then we have third, that is hepatic angiosarcoma, it is not associated with any infection. Leukemia can be associated with EBV infection, but is it that it is controlling it? No, it doesn't seem like. Then pulmonary small cell carcinoma, no. The most importantly, we can see the incidence that has reduced and could be the number of deaths that has reduced in developed countries is gastric adenocarcinoma, as there is reduced H. pylori infection. Then we come to the 14th MCQ. An epidemiological study of the cancer deaths recorded in the last half of the 20th century was conducted. The number of deaths from one particular cancer had increased markedly in the developed countries. More than 30% of cancer deaths in the men and more than 24% cancer deaths in the women were caused by the neoplasms in 1998. In some nations, preventive strategies reduced death from this cancer. Which of the following neoplasms is most likely identified in this study? Okay, so they say this is a malignancy that is causing a very high number of mortality. So which of the following names are most likely identified in the study? So this is cerebral glioma, bronchogenic carcinoma, hepatocellular carcinoma, colonic adenocarcinoma, pancreatic adenocarcinoma, or skin melanoma. So let's study this again. An epidemiological study shows the number of deaths from a particular cancer had increased markedly. Increased, but it not decreased, it is increased in developed nations. More than 30% cancer deaths are in men. Matlab men means men more than women. Has caused by this neoplasm in 1998. So out of all the cancer deaths, 30% are due to this cancer. In some nation, preventive strategies reduce death from this cancer. So what can be the preventive strategies? Maybe reducing smoking, less of the pollution, less exposure to pollution. So is there any difference in glioma from decades? No. Hepatocellular carcinoma? No. Colonic adenocarcinoma? Maybe screening of colonoscopy, but that's not very much improved. Pancreatic adenocarcinoma and skin melanoma. So the answer is bronchogenic carcinoma.